Welcome to Madeline and Tom's Journal Club assignment. Today we'll be looking at the article Circulating PCSK9 is associated with liver biomarkers and hepatic steatosis. Non-alcoholic fatty liver disease, or NAFLD, is the leading cause of chronic liver diseases in Australia, New Zealand and the US. Its prevalence is highly correlated to the increase in incidence of obesity, type 2 diabetes and cardiovascular diseases. NAFLD encompasses a variety of diseases in the liver that stem from an increase in triglycerides or fat being deposited in hepatocytes. Initially, diagnosis of NAFLD is when a patient has a presence of triglycerides in 5% of their liver cells. Without intervention, this condition can lead into non-alcoholic steatohepatitis, also known as hepatic steatosis. Hepatic steatosis is characterized by the inflammation of hepatocytes and can include the presence of fibrosis. The fibrotic stage of the disease can also lead into liver cirrhosis, where the vasculature of the liver is impaired and organ death can begin to occur. Due to the progressive nature of non-alcoholic fatty liver disease, late diagnosis usually occurs in individuals suffering from the condition, as their condition is commonly asymptomatic. The need for developments in current diagnostic protocols is really in high demand, as it's estimated that 6.4 million people in the US that have hepatic steatosis will cost the healthcare system approximately $2.79 billion every year for the next 20 years. And aside from this economic burden, liver disease has a really high mortality rate of 85% of patients who need a liver transplant due to cirrhotic conditions in their liver. Therefore, it is essential that healthcare providers regularly screen for non-alcoholic fatty liver disease in at-risk individuals or patients with a family history of the condition. Diagnosing non-alcoholic fatty liver disease and hepatic steatosis is quite a convoluted process that requires tests, scans, and biopsies for a confirmative diagnosis. The clinician initially looks at the patient's circumstances to see if they are at risk or have a family history of fatty liver diseases. The patient's symptoms are then also analysed, and while most cases of NAFLD are asymptomatic, the common symptoms that are seen are fatigue and right upper quadrant pain or dullness in the abdomen, which can be felt during physical examination. Biochemically, we test for NAFLD through analysing the aminotransferase enzymes, AST and ALT, and glutamyl transpeptidase, or GTT. AST and ALT are usually only mildly elevated in serum in these conditions, with only levels of only 1 to 3-fold higher than the upper normal reference limit. In fatty liver conditions, the AST to ALT ratio is usually less than 1. GGT can also be used as a diagnostic factor, as it can sometimes seen to be elevated in serum, but it's not very conclusive for fatty liver diseases. It's more of a supporting test of the AST and ALT results. Unfortunately, these liver enzymes are associated with many other liver conditions, and they aren't the most conclusive and selective diagnostic test for liver disease. Ultrasound tests can be conducted to assess for steatosis. Presence of steatosis can increase the echogenicity in the scan, which would indicate NAFLD conditions. The issue with ultrasound is they are not the most accurate in diagnosing steatosis, as the scan isn't selective for the condition. The only definitive and recommended diagnostic strategy is conducting a liver biopsy on the patient. A liver biopsy provides definitive diagnosis, defines the presence and degree of injury or fibrosis to the liver, and establishes a baseline for future monitoring of the progression of the disease. There are very few options to treat non-alcoholic fatty liver disease and its associated conditions. The main intervention is for the patient to lose weight and maintain a healthy BMI. They can also take amino acid supplements and antibiotics to help stop the progression of the condition. However, if the condition does progress to cirrhotic stages, where the liver function is severely impaired, they will need a liver transplant. Overall, the current diagnostic protocol does not quickly and easily identify fatty liver diseases, and new developments in biochemical diagnostics is really needed to diagnose the condition as early as possible to avoid disease progression into fibrotic and cirrhotic condition.
Due to the ever-increasing prevalence of metabolic syndromes and hepatic steatosis, which is the medical term for fatty liver disease, researchers from Montreal, Canada have conducted clinical experiments on a large cohort of Kenyan individuals and published a paper regarding the association of a circulating protein called proprotein convertase substolin kexin type 9, or PCSK9 for short, and also well-known liver biomarkers such as ALT, AST, ALP, GGT, and bilirubin. This association comes as an extension on current literature which was previously controversial for some other research groups, such as some from France, and this study hopes to add to the current literature on non-alcoholic liver disease, which currently has a global prevalence of between 25 to 35% and represents the most frequent cause of liver enzyme elevation in blood, which is quite significant. There is currently no other liver biomarkers used as a gold standard in clinical biochemistry, and biomarkers are always researched as equipment advancements allow for a more sensitive measurements to be made and ultimately the improved health outcomes that follow these kinds of discoveries. The aim of this study can be seen here, and it was to investigate the association between circulating PCSK9 and other circulating liver biomarkers, as well as the presence of fatty liver disease in a large cohort study.
This study coincided with the diabetes study in Kenya. The volunteers from the Kenyan study were invited to participate in the PCSK9 study if they matched certain selective criteria. The chosen volunteers were over 17 years old with mixed ethnicities, had a good mental health and no known serious or chronic illnesses or impairments. The volunteers then had an ultrasound, and the scans were assessed for steatosis presence on each liver and branded them on a normal, mild, moderate or severe scale. They then had a circulating PCSK9 test, which was analysed by an in-house ELISA immunoassay. The research group used a polyclonal antibody that has been tested against human PCSK9. This assay was developed by another research group in 2009, which also correlated the levels of PCSK9 in plasma with age, sex, and metabolic markers. The volunteer serum was then tested for various liver enzymes and biomarkers in a semi-automated clinical analyzer machine. The substances being measured included albumin, ALP, AST, total bilirubin, ALT, and GGT. The volunteers that were selected for the study, their BMI, blood pressure, lipid profile, body proportions, and glucose metabolism was measured, as well as their life and alcohol history taken. Using all of this data, certain variables were analysed in conjunction with each other to see if there was any correlation between circulating PCSK9 and bioliver markers or hepatic steatosis. To analyse the results produced, there were many statistical correlation tests used to produce the results of this paper. Some key points from this analysis is that all p-values were deemed statistically significant if they were less than or equal to 0.05. The p-values were calculated for the student's t-test for continuous variables and a chi-squared test for categorical variables. A linear and logistic regression model was used to statistically correlate the main variables of the study. This is PCSK9 with biomarkers or hepatic steatosis.
So the outcome of this experiment was the strong association between circulating PCSK9 and hepatic steatosis. As you can see in this presentation, 104 of the near 700 participants presented with fatty liver disease and were on average 5 years older than the people who were not categorised as having fatty liver disease. There were 3 different regression models used to describe the association between hepatic steatosis and circulating PCSK9. The first one was not adjusted for any confounding variables and unsurprisingly gave the strongest association with a p-value of less than 0.0001. The next regression model was adjusted for age and sex of the cohort participants but still returned a strong association of 0.005. The final model was corrected for age, sex, BMI, and alcohol use, amongst others, and still presented a statistically significant p-value of 0.02, which provided the overall argument and strength for the paper. The main findings of this paper are the strong association of PCSK9 and hepatic steatosis with other known biomarkers. These results provide invaluable knowledge to liver biomarker research and the clinical diagnostics of hepatic diseases presently experienced worldwide. The findings were based on a robust statistical method with the use of multiple methods of modelling. This research group used a well-rounded approach with strong experimental and statistical methods and confirmed a strong relationship between the two variables, i.e. PCSK9 and hepatic steatosis. The positive association of PCSK9 allowed for further diagnostic value, as traditionally elevated levels of these enzymes is usually considered an indicator of abnormal liver function. Although traditional methods show abnormal liver function, these are not associated with fatty liver disease. There is some evidence from a group at the American Heart Association saying that GGT has an association with some metabolic syndrome and also cardiovascular disease too. However, the mechanisms behind this relationship largely remain unclear. The negative association of bilirubin was as expected, as well as in the fatty liver positive cohort, as previously described by Chang et al. In a study in 2012. It is still unclear which type of bilirubin has this inverse relationship, either the unconjugated or conjugated form. The data presented in the results of this paper showed a strong association between circulating PCSK9 and hepatic steatosis, as well as other common liver biomarkers, which is an addition to current literature in support of this claim. There are research groups with conflicting claims on this topic though, and they will be discussed later in this presentation. There were no published quality controls in this paper, however this research group had provided reference to protocols and methods within older papers that they had used before. Also, with the use of a COBAS automated clinical analyzer, we could assume that appropriate data inserts would have been used to match the Kenyan population data in this study. The limitations in this study were conflicting on the strength of the argument. However, still allowed for a strong claim with the biochemical results obtained. The diagnosis of fatty liver disease was carried out by only one researcher by ultrasound and may present as a confounder. Perhaps the research group could have had multiple blinded radiography opinions to reduce the possibility of bias. Another challenge was the lack of testing for infections that may have caused some variation in serum biochemistry, such as HIV or other common viral infections endemic to Kenya. Potentially running PCR testing prior to acceptance in the study could alleviate this issue. A final issue that was presented in this study was the self-reporting of alcohol consumption. Due to the effect alcohol has on the liver and the relevant liver enzyme levels, it was suspected that underreporting had occurred and therefore accurate statistical correction for this variable was not possible.
In critical discussions of articles, it's really essential to look at some supporting and non-supporting claims in research. So for this article on the utilisation of PCSK9 in the diagnostics of non-alcoholic fatty liver disease, it's really been quite a controversial debate within the scientific communities. There have been so many studies found supporting and confounding evidence for the marker being elevated in NAFLD. However, I'll be presenting some supporting claims that help the article's claims that PCSK9 is a factor in non-alcoholic fatty liver disease. In 2010, an article written by a French research group led by Bertin Carrigal found a positive association between PCSK9 and gamma-glutamyl transferase in diabetic patients. They found that since PCSK9's regulate function is to act on the LDL receptor in the liver, and when the metabolism of fats and carbohydrates is altered in diabetic conditions, PCSK9 plasma concentration increases. Further recommendations from this study stated that PCSK9 could be a link between type 2 diabetic patients and fatty liver disease. This is because type 2 diabetics are already at a high risk of this condition. The PCSK9 could actually be a component of the individuals developing the fatty liver conditions. This research group did conduct further study into these claims. In 2016, another research group from Italy correlated circulating PCSK9 and hepatic steatosis. This group did this very accurately by conducting liver biopsies on 201 volunteers, where they diagnosed hepatic steatosis, and then they conducted an ELISA assay for circulating PCSK9, similarly to the one we described in this experiment. The group found that as the progression of non-alcoholic fatty liver disease progressed to fibrotic and cirrhotic stages, the circulating PCSK9 levels in plasma also increased. From this study, they concluded that PCSK9 increased in circulation as a result of hepatic steatosis, and that it could possibly be utilized as a biomarker for understanding the progressive stage which the fatty liver is in. Both of these studies demonstrate that PCSK9 can be a key indicator in individuals at risk of NAFLD or individuals who already have the condition. We can utilize this information as well as findings from the original discussed study to understand the mechanism of PCSK9 and its increasing in circulation in the above described conditions. However, we need some more research and concluding evidence to see if this is the case.
Another important study that was later completed in 2018 by the same French research group noted no association between PCSK9 and liver fat content on a cohort of 478 people from 3 French hospitals. Now, although this group had a relatively large cohort, they were still unable to exclude the effect of PCSK9 on the liver fat content in general, but they did discover that circulating levels were not associated with the severity of steatosis as its own variable. This meant the association between the other liver biomarkers and steatosis in general still remained unclear, and provided a gap or area of interest for the Canadian-based researchers to further explore. This eventually resulted in the publication we've been discussing, which came 2 years after the research group from France proposed no association at all.
Now that we've discussed some confounding and supporting evidence for this study, let's have a look at how we can improve the study conducted by the Canadian Research Group. Overall, PCSK9 to be considered as a potential biomarker in fatty liver diseases, there needs to be some higher quality research overall. And in particular, in this study, there are a few key issues that need to be executed more accurately to produce more reputable results that can challenge any confounding research within the scientific community. In summary, these include using a liver biopsy technique instead of an ultrasound, as it's more accurate in diagnosing hepatic steatosis, ensuring that the research group tests for other conditions or diseases that could affect PCSK9 levels, including alcoholism, HIV, and viral and inflammatory diseases. And finally, this research group should use a more representative cohort that reflects the prevalence of non-alcoholic fatty liver diseases within society, as using the results from a developing country's population would not be reflective and useful in application into Western society. Western societies have the highest prevalence of fatty liver conditions, and research should be conducted in this community so we can recommend diagnostic and treatment advances to the targeted individuals.
So the data within this paper suggests a strong association between PCSK9 and liver biomarkers, as well as hepatic steatosis. Further studies are needed to explore the role of PCSK9 on hepatic function and the sensitivity it gives to current diagnostics, especially within the context of disease. Although this paper adds to and argues against current literature, it expresses the need for healthy discussion in the clinical biochemistry field. By exploring controversial hypotheses, we may be able to discover potential areas lacking strength, but with potential for clinical benefits. Critically analysing scientific works was a skill that was further developed during this research, and gave insight into reviewing literature that is relevant to the field of liver research and the associated biochemistry. Future studies could add to or rebut against this paper, which will ultimately allow liver research to progress forward and add to the overall goal of reducing or eliminating liver disease morbidity. Thanks for listening to our presentation. Feel free to have a look at the references we used on the following slide.